your introduction, Irabor, and I'm delighted to entertain you for a few minutes on the issues of cancer surgery. I'm grateful to the Harvard Catalyst, and of course, I fully support the Win-Win Initiative, and my best wishes to Professor Ahmed El-Zawawi, who I understand is the chair of the radiation oncology course. Now, let me just see whether I can move these slides forward. This is Sweden. I just want to reassure you that today the weather is not bad. It's 6 degrees. It's pretty pleasant, and the ice is melting. So don't you worry. We are doing fine. On the broad outlook, the Greeks were the ones who first coined the terms oncology. Oncos, it comes from cancer, and there are medical oncologists, there are radiation oncologists, there are nursing specialists dealing with cancer patients, and of course, today we are touching on cancer surgery. Surgery comes from Greek again. Surgery is whatever is done with your hands. The word chirurgia means a hand product. So this is what surgeons do. They move their hands in a way to eradicate cancers. We have to see how, when, and why. But the idea is to remove the cancer. And you want the all cancer out. On the left, you can see that this cancer is appropriately excised, whilst on the right, you don't want to leave half cancer in the patients. On the pathological specimen, you can have these sort of findings with safe margins. That's what we aim for surgery. And of course, there has been lots of literature touching on the width of the margins, how big the margin should be, 5 millimeters, 3 millimeters, 1 millimeters, and we can discuss this for ages, and lots of literature has been developed on this point. And here you can see that the specimen that was taken, this was a breast cancer that we excised, was marked with some silk setons for the pathologist to orientate and adjust the excisional lump. And here you've got a lovely imaging, an X-ray finding that shows that the cancer is in the core, bullseye, the cancer is nicely excised, at least this is what we hope. I'm starting this conversation with you straight from the core of the margins, because I want to discuss with you the fact that surgeons deal with a lesion, with a biological entity, which is not necessarily mathematically figurable. In a way, we do know that the width of the surgical margins affects the local recurrence. And of course, sometimes someone might say that it reduces survival. And of course, there is emotional distress when the patients need to go back to surgery for a second excision. In fact, 1 in 4, 1 in 5 breast cancers tend to be re-excised, and most of this time the re-excision is actually useless because it shows that there is no affected margins in the re-excisional tissue, and those patients who are at a higher risk of undergoing re-excisions are the ones that are triple negative with the highest local recurrence rates. I don't want to shock you, but I'm sure you are aware that a huge meta-analysis took into consideration almost 15,000 patients and could not show any difference in terms of survival for those patients who had 1, 2, or 5 millimeter margins. This is precisely what I wanted to start with. Negative margins do not mean that there is no cancer left, and you cannot convince yourself that you've done a terrific job simply because the margins are clear. In fact, we know that if all breast cancer patients had an MRI, you would see some 15 to 20% patients affected by additional foci, not far away or even in distant sites at the mammary gland, but this does not impact on the overall survival. What I'm trying to say is that the geometrical understanding of the excisional margin does not match with real world. In fact, the big issue is the histology, is the biology of the disease, rather than the millimetric measurement of the width of the margins. And I have some literature with you, which over the last 10 years have confirmed and reiterated how surgical margins in the lumpectomy do not really mean that the bigger the lumpectomy, the better is the outcome. Here is the meta-analysis that I wanted you to familiarize with. So in a way, margins are important, but the biology is crucially more important. R0 stands for no cancer cells that can be seen microscopically on the edges of the excision. R1 means that some cells are seen on the margins, and R2 is when the surgical removal is inadequate and the surgeon has failed, even on a naked eye, to remove the whole cancer bulk. Now, why is this? Why do we not do a good job at times? Well, let me just say that when you take a pancreatic cancer out, you might consider that there are nearby vessels, very important structures that you cannot excise without affecting, for example, the vascular supply of the gut. When you're dealing with rectal cancer, sometimes you are very close to the sphincter and the muscles that are relevant to continence, and you don't want to damage that. Sarcoma can be excised, but sometimes a wide excision would end up in amputation. And of course, for melanoma, you always consider the cosmetics of the outcome. I have here a couple of drawings where you can see that this pancreatic cancer is excised, but down here, the mesenteric vessels should be excised with post-operative complications. And here is the splenic vein that can be safely excised, but this entails a much more aggressive surgical procedure. I was touching on rectal cancer, when you can see here that the removal of the rectum sometimes affects the continence because of the nearby structures. And when you're dealing with sarcomas, wider margins would end up in the removal of the whole compartment, therefore the amputation of the limb, for example. And you can see here how the cosmetic can be affected when the wide excision entails a flap or a rotation flap to be taken into consideration. I want to leave this issue on the margins, and I want to drag your attention to the fact that most importantly, over the last 10, 20 years, we have been moving from tissue diagnosis and tissue-based treatment to molecular diagnosis, that is genetically informed oncology, which has definitely altered our surgical and medical approach. In the setting of tissue-based treatment, we have non-specific and high toxic treatments resulting into small benefits, whilst in the setting of pathway-driven treatment, we have personalized treatments with high benefits and much lower toxicity. You understand that this is a paradigm that affects the whole oncological treatment, not just surgeons, but of course in your practice, whatever your specific interest is. So this is a very important revolution which we should take into consideration when we are discussing the treatment plan for our cancer patients. Next step, of course, is understanding the biology and the cancer recurrence or the occurrence or the progression or regression, not just by taking a sample, but by measuring the circulating DNA tumor burden, which is, of course, a biomarker for cancer diagnosis. It helps monitoring treatment response and the disease progression and so on and so. This has already become clinical practice for some neoplasms, for some tumors. I'm thinking of lung cancer particularly. It's not widely available, but I'm sure that this will become one of the standard for future reference. Just to drag you to some other topics, here's a picture of me holding a retractor because they don't allow me doing anything more important in theater. I'm just joking, but I'm still clinically active. I want to drag your attention on the fact that nowadays, simply on what we have been discussing so far, nowadays there is no role for the magic surgeon with the golden finger who can control cancer better than anybody else. This is something that belongs to the past, and I think that for the time being we have patients at the center of our attention. They refer to surgeons for their disease, for their complaints, but then surgeons, when the workout has been completed, discuss the evidence with pathologists, with radiation oncologists, medical, clinical oncologists, depending on the setting, with cancer care nurses, and with psychologists and so on, so that we have a lovely environment where all aspects of the biology and the psychology brings us to, gives us the opportunity of offering each individual patient the most appropriate treatment plan. And here is one of our routine meetings where we have all involved parties sitting together. Now, the MDT is in fact tricky to organize. It's not perfect in every sense. There are, of course, sometimes personality clashes, and there are constraints due to the fact that you need infrastructures, you need some time set apart to prepare for the MDT and to run the MDT all together with your colleagues. It's a matter of auditing, measuring what has been discussed, recording it, and documenting it and looking at it retrospectively so that you can improve the decision-making process. I'd love to believe that patients have been involved or are being involved, maybe not physically present, but through the cancer nurses who are very close to the patients. And I also believe that the MDT is a wonderful opportunity for educational purposes, for training purposes, and for research as well, because we can learn and teach ourselves and maybe teach our colleagues how we deal with individual problems. We also like to believe that what we learn from the MDT helps us in optimizing the way that we follow up our patients and the way that we deal with long-term outcomes. That is not just cancer outcome, but functional outcome, psychosocial issues, functional, cosmetics, and so on. So I'm here to say that the surgical oncologist is actually the one who deals with the removal of the cancer, but the tricky part is not just taking it out, because this any general surgeon can do. The problem is how to do it, when to do it, and why to do it. Of course, you're aware that there are different surgical subspecialties. You can see a large list here, and everyone has different targets. Of course, inflammatory bowel, for example, belongs to the area of coloproctology, but those who deal with inflammatory bowel disease maybe are not necessarily well trained in cancer surgery. There are indeed new techniques that are being developed and invented, created, and popularized. I'm thinking about chemoperfusion, which has been used and still is being used for sarcomas, melanomas, alone or in combination with immunotherapy. Chemoperfusion also has been attempted in dealing with liver cancer, maybe breast and pancreatic is still experimental, but I'm sure you're aware of the HIPEC, to deal with peritoneal malignancies, and minimal access surgery has been penetrating the surgical armamentarium massively. I'm personally not great fond of robotic surgery. I think that you do not want to invest a huge amount of money into robots, because at this moment, the present generation of robotic surgery is not up to perfection. I think it's very expensive, and there is no hard evidence of a massive gain. But I'm sure that in the next few years, better equipment and better tools will be made available. So all these new techniques are being proposed and introduced into the market, and surgical oncologists need to be aware of these techniques, but at the same time they also need to be skeptical, because you wouldn't take for granted whatever is being launched on the market. And for the purpose of enhancing the discussion and creating a vivid environment of discussion and training and education, we have several societies who really target this. I'm starting with the oldest one, which I want to credit, the SSO, it's the American Society of Surgical Oncology. And the goal that they have set is to represent surgical oncologists, to promote multidisciplinarity, to provide education and training, to promote clinical and translational research, and facilitate career development while promoting public policy. because this is also important. You can have crazy people who developed magic techniques and they try to convince you that this is all right. But in fact, this is only accepted when rigorously experimented and validated. I want to mention BASO, which is the British Association of Surgical Oncology, that was founded in 1973. I had the honor to be the president of the British Association of Surgical Oncology. And I also want to mention ESSO, the European Society of Surgical Oncology, which was founded in 1981 for the purpose of advancing art, science, and practice of surgery in the treatment of cancer. I encourage you to visit the ESSO website because there are several interesting aspects, including a list of fellowships, educational programs, webinars, and lectures that are broadcasted where you can easily link in or maybe assist or point your surgical colleagues to take part. We have a large number of international fellows, including guys from Africa, from the Far East and South America. Therefore, there is no boundaries when we discuss education in cancer surgery. Everyone is very, very welcome. In our website, we have an interest in defining minimal standards. And I really prefer discussing minimal standards rather than casting guidelines. Excuse me. Because guidelines can be perfect, really, really perfect in my place, but maybe they don't suit your place. Maybe the facilities are not there, the geographical environment, the logistics is not there. So it's very, very difficult, if not inappropriate, to define guidelines. I would really prefer discussing minimal standards. That is, what is it that is absolutely crucially important not to miss out? And these are issues that I'd like to touch on with you. I point you at the BASO minimal standards in the management of breast cancer, which I recognize now. It was published in 2009, that is 10 years ago, and it shows how quickly time flies. We are putting an effort here in Europe to define minimal standards for a number of malignancies, colorectal cancers, upper GI, breast, gynecological cancer, urological cancers, and we are in the process of publishing all these. All this happens with the comprehensive collaboration of all these societies, the Italian Society of Surgical Oncologists, the Spanish one, the Belgian one, Israeli, and whoever wants to take part is more than welcome. National societies, of course, are crucially important simply for what we discussed before. It is difficult to believe that you define optimal treatment without merging with the local facilities, with the local needs, with the local understanding and local facilities. So national societies have always been very useful in helping us to deliver training and education, and also in the process of offering qualification. Bearing in mind that in Europe we do not have as yet fully recognized qualification in surgical oncology. Also in the States, where this is now available, only a few years ago, and I mean 4 or 5 years ago, SSO, as I mentioned before, is pretty well recognized. but had no official qualification in terms of defining who is a surgical oncologist. Now they have achieved this, and we are very eager to follow their steps and achieve this in Europe as well. To walk on this path and to help our alumni and our universities and our politicians to define surgical oncology as an autonomous entity, we are happy to set up a core curriculum, which was published a few years ago. And the next step after this publication was a joint venture together with our American colleagues. So we sat down with the educational team at ESSO and SSO, and we said, why don't we try to pin down what should be offered to our cancer surgeons wherever they are across the planet. This is not an all-inclusive or an all-encompassing approach, and not everything can be applicable in all countries, but it has the aim to bring together those who are interested in cancer surgery. And here we go. We have this lovely piece of literature published, and Chandra Are from the States was the main propeller behind this task force, and we really sat down and we put down a few thoughts that I want to share with you. Oh, a nice picture to see that we were showing all the flags. Now, what is it that you need to become a surgical oncologist? Well, core domains. Core domains, yes, you need to do your surgery well and you need to master your techniques. But this is not really what surgical oncology societies are after. This is for the college to endorse, to confirm that you are competent, that you are skilled, that you are well trained. And surgical oncology as a society is much more a philosophy rather than a body that trains into how to perform a procedure. I want this to be very clear. It is beyond our interest to master the technique. Our interest is more in the philosophy of how to do it, when to do it, and why to do it. Of course, you want to be aware of different approaches, and you want to be aware of what is patient selection. You want to be aware of the selection criteria, and you want to discuss risk stratification, which is crucially important for surgical oncologists to have well in mind when you're discussing the risk and the benefits with patients and with the relatives. Of course, you need to set up the appropriate staging that will help you planning the best operative treatment. And there are psychological issues in informing and consenting patients. And there are also legal issues that you need to be aware of. And finally, intraoperative care and post-operative care. So these are the technical skills that we recommend. But there is also some essential knowledge that pertains to different cancer sites. Let's take breast, colorectal and anal, upper GI, small bowel, liver and biliary tract, pancreatic cancer, endocrine, of course, cutaneous oncology, sarcoma. We have a school of sarcoma and a school of peritoneal malignancy that are in charge of completing the training for those who are interested into these malignancies. And finally, I want to raise this issue because we found that not only you need to know how to operate and how to decide which patients and which is the most appropriate treatment for each individual patient, but you want to remember that the patient is the center of our focus. So all our treatments should be in the best patient's interest. All our multimodal approach should be patient-centered, and this is based on our medical knowledge that we want to share with patients, and we want to reiterate this interprofessional teamwork, and of course we want to polish up communication skills. You well know, particularly the younger ones know how difficult sometimes is to put through some sad news, breaking bad news, and disclosing some sad expectation. We also want to make sure that who deals with cancer surgery is competent in experimental learning. And finally, I think it's important to remember, whatever our specialty is, that we are dealing with humans and that we want to be compassionate in our clinical practice. But we also need to know how to best read the literature. I'll give you an example here. You might have heard, this is breast cancer, intraoperative treatment for breast cancer with the Target trial that was published a few years ago. And it was very much pushed by the industry. And this investigation, although accepted on high-profile journals, was really, really borderline. And there are still vivid criticism suggesting that the power of the study was not appropriate, the selection was biased, and these criticisms still go on, showing that in a meta-analysis the benefits are not all on one side and the evidence is not entirely convincing. What I want to say is that we live in a world where we are happy to learn, we want to be open and assimilate what our colleagues want to deliver, the information that they have to teach us, but at the same time we need to be aware and skillful in reading the literature. So a little bit of basic maths, epidemiology, statistics is crucially important wherever we are. In fact, this meta-analysis concludes that there is no enough data to draw any conclusions even 5 years down the line. So in essence, is surgical oncology better than general surgeons? Well, I think that it's over 20, 30 years that we have hard evidence to show that those who deal with more surgical procedures, they have better outcomes. In this case, esophageal cancer, surgeons have less leaks, less mortality, and more and improved long-term outcomes. This is a series on colorectal cancer showing that colorectal surgeon specialists, they are the most important prognostic factor for those 79 colorectal cancer patients. We know that when assessing a cohort of colorectal patients treated between 74 and 79, and another cohort treated 20 years later, we know that the huge advantage in survival is not due to an earlier diagnosis, but is definitely due to a far better surgical treatment. Not because we have better tools. In fact, we use the same scissors most of the time and the same forceps that we used to. but we have learned how to progress things in a far better way. Breast cancer is another obvious example. Breast specialist surgeons offer a threefold increase when the same breast cancer patient is treated by a general surgeon. And another couple of reference here confirming that the 10-year survival is 8 to 15 times higher when dealt with by breast cancer surgeons. And here is a meta-analysis on pancreatic cancer surgery, where obviously skilled and high-profile centers deliver far better outcomes. So surgical oncologists are better because they can tailor the surgical treatment after extensive discussion, after learning and hearing what medical radiation oncologists have to say. They have better cosmetic outcomes and functional outcomes, and this results into a far better quality of life. Remember that there is a vast cohort of patients, patient survivors, and these patients will live, the lucky ones who will survive their cancer treatments, they will have to deal with the outcomes and with the drawbacks of the medical and surgical treatments. Therefore, optimizing functional outcomes is very important. It's important to know that we are trained in better dealing with patients and relatives. I mentioned before breaking the bad news. There are important medical legal aspects, regulatory issues, which are becoming more and more prevalent. And last but not least, I want to mention some specific skills in coping with grief and depression, because it's not, well, it can be very sad and very difficult to deal with a lethal condition. Therefore, the depression, including suicide rate among surgeons, is pretty high. Therefore, it's important to be aware of the burnout, of the sad aspects of our profession, and being skilled in making the most of our human interaction. I want to spend a few words on research and just remind you that the investment into research in surgical oncology is very minute. In the UK, has been doubled, going from 1% to 2% over the last 15 years. And just be aware that almost all the research comes from a restricted number of 35 countries which are contributing to this. And this is a shame, because not all what is appropriate in the United States or in Europe might be appropriate in low or middle income countries. Therefore, it's important to develop research, clinical research and surgical research wherever we practice. Looking at the more sophisticated aspect of trials, of course, surgeons have to blame themselves for not being very good in entering patients into trials. There is a number of reasons for that, and procedures are not standardized. So if I run a trial where I want to say this procedure against procedure B, now I can practice the two procedures my way, and my colleagues next door might have a different performance. Therefore, the standardization has to be taken into consideration. Credentialing is inconsistent, and the surgical control is the same. Accessibility is not always there. And just be aware that 1 in 5, 25% patients enter into surgical trials are discontinued. And of course, there is lack of sponsorship, because different from Our medical colleagues, we have very little budget. There is no big pharma behind us. Therefore, the research is really not florid. But I also want to be a little bit critical with you, talking about trials. I hope I'm not shocking you here. You are too far away from me for throwing me out of the window, but I'm going to share these thoughts with you. Now we look at the trial as the perfection, as the gospel of clinical science, of oncology particularly. But just be aware that it's less than 3%, probably closer to 2% of the whole cancer population that is entered into a trial. And this very minute minority is usually super selected. They are fit, they are more knowledgeable, they are financially privileged, they are younger, they are better nourished, and so on. Interesting, pain points tend to change all the times according to the different medications. So we do not use overall survival, cancer-specific survival, but most of the time we use some proxy, time to recurrence, time to symptoms, time to progression, and so on. And most dramatically, negative results are often unpublished. Therefore, when I want to review the literature and present a nice wall, a nice wide meta-analysis, I end to neglect the large number of investigations where the target was not achieved. Therefore, what I'm trying to say is that the meta-analysis is usually very skewed, and the result is biased. I doubt that these days of modern medicine, trial is the gospel any longer. And in fact, there is a recent publication here on the British Medical Journal showing that financial ties of the principal investigators and randomized controlled trial outcomes are often biased by the sponsorship. What is very good in surgery, which is not always the case for medical and clinical and radiation oncologists, is that we do have outcomes. Let me just dissect this and let me clarify what I want to say. We do not trust anecdotal evidence. We don't want to sit at the pub and say, oh, I've done this procedure, I've done this other, mine is better than yours. We said that I'm skeptical on clinical trials, but what about if I was to tell you that we have hard evidence to show that over 500 breast cancer patient deaths are preventable out of 1,000 with surgery. We know that surgery can cure 50 to 60% breast cancer patients. I want to mention rectal cancer. The local recurrence for rectal cancer used to be 20 to 25%, and nowadays it's less than 10%. Distant metastasis used to be 45, 50%, and now it's been halved. The overall survival is up to 60, 70, sometimes 80%, and the local recurrence rate has dropped from 1 in 3 patients to 1 in 20, occasionally 1 in 30%. These are remarkable figures. This is all due to good surgery, and this is what has happened after the introduction of a technique which you might have heard of, and this is total mesorectal excision. Total mesorectal excision was introduced in the 80s, and it's been performed by Bill Hill, who promoted it in the UK and in Ireland, and then he went around teaching TME in the Netherlands and in Scandinavian countries. So since the introduction of this technique, Not a trial was performed, but since it was introduced, we know that 5 years later, and now 10 years later, and 20 years later, these remarkable figures, these nationwide local recurrence has dropped dramatically. And of course, this is far better evidence than recruiting a few hundred patients into a trial. So this is the field which I congratulate wholeheartedly, and he got a tie from us to celebrate his massive contribution. We have other occasions, other evidence of phase 4 clinical trials, good quality registry, real-world population-based research, and this is the watch and wait technique, where rectal cancer is being treated conservatively with radiation treatment primarily, and this has achieved a very huge series of rectal cancer patients who are being offered or not surgery beyond the radiotherapy, and this is being looked into in great details. So this is a prospective accrual. And here is another example. A few years ago, we launched a registry. There is an ongoing one in the States, as far as I'm aware as well, where breast cancer patients received skin sparing and nipple sparing mastectomy. Somebody says, no, this is not an adequate procedure. Somebody, it's a beautiful procedure. And we don't know, but we cannot randomize patients here. We can only offer them a procedure according to their request, but let's monitor these cases prospectively, and therefore we have 1,000 patients recruited now through an international collaboration, which we are looking into with great interest. And the final one I want to mention is the Go Safe. Some of you might be aware that I'm passionate about good quality surgery for all the patients. And the Go Safe is an international cooperation where all the patients are framed for fitness, for frailty before surgery. They are scrutinized very thoroughly, and then they are operated, whatever the treatment plan is locally. And few months and years after, they are reassessed to see whether we have done the right job and which were the ones that we should not have operated on, and on the other hand, which are the procedures that we should offer. Now, on a global scale, let me remind you that the figures are rather impressive. We have some 14 million new cancer cases per year, and 8 million cancer deaths, and the 33 million patients living with cancer are also noteworthy. This was a few years ago, but the predictions is that these figures are going to double. So be prepared to do a good job, because your hard work is mandatory. But also be aware that 80% of all cancer patients will need surgery at some point. And we want to be able to offer them good quality cancer surgery. Surgical oncology is indeed a major pillar of cancer care. In cure patients, prevent the disease, make the diagnosis and staging, provide supportive care, palliative care, and sometimes in reconstructive. Of course, we want to deliver cancer surgery in a safe way, in an affordable way, and in a timely manner. There is not a huge number of surgical procedures that we deal with. It's less than 300 procedures that we have to be aware of, and only 100 maybe are super specialists. The largest majority can be performed, and in fact are being performed by general surgeons worldwide. So my input here is to enhance the interest, the attitude, the curiosity of general surgeons to look into becoming a surgical oncologist. In 2015, we had 32 million cancer surgical operation, not only here on the left in very high income countries, and you can see the projection which is on the raise, as I was saying, but also in low and middle income countries, you can see how more and more surgical procedure will be performed, so that these are the figures overall worldwide with a huge increment for the next years. Regrettably, low-income countries have less than 5% patients who have access to safe and good quality surgery. And the moderate income are approximately around 20 to 30%. Now, this is kind of crazy because particularly in cancer treatment, more than in any other disease, including emergency surgery, good quality cancer treatment, surgical cancer treatment, results in a gain, in a financial gain. It's an investment in the health of our population. So what we want to do is to choose the best and the easiest way. For example, we can use breast ultrasound and simple biopsies instead of looking into sophisticated MRIs, which are possibly not resulting into huge gains. We want to select what is safe and what is achievable, and we want to make sure that most complicated, most complex surgical procedures are delivered centrally in centers of excellence. And we want to train younger colleagues, whatever their oncological specialty, to be active in their multidisciplinary environment and to move from old style bedside medicine to modern training. I think that we can take advantage of nurses and train oncologic nurses wherever we are. They are splendid partners of our clinical practice. We can use telepathology and mobile units more and more with the expansion of artificial intelligence. This is becoming cheaper and affordable. And again, please make sure that we audit, we record our mistakes, and we improve from what we have learned. This is not to blame anyone, it's just to make sure that we improve our performance day by day. The issue of cost effectiveness is therefore very important. And again, of all these important factors is the patient himself or herself. The care that we want to deliver is importantly centered toward patients. And I've finished my conversation with you, just inviting any one of you to consider reinforcing the team of surgical oncologists. Thank you.
Thank you very much, Professor Audisio. So I'll throw the class open. I'll throw it open to the class to ask their questions right now. So you can ask any question. You can unmute your microphone and speak, or you can type, whichever one.
Okay, I have a few minutes for you, so I'm happy to pick a few questions. Yes.
Okay. Someone is speaking. Okay, so I just have a few questions, Prof.
Yeah.
For the indication for for surgical, for surgery in the treatment of cancers. So, is there any statistic that shows what percentage of each cancers would require surgery? For instance, breast cancer, thoracic cancer. What percentage? I mean, for possible analysis. So, is there any way to know it specifically down to the cancer groups or cancer sites? What percent of patients with lung cancers will require surgery, and so on and so forth?
Okay, this is an interesting one. Thank you for this, because it allows me to criticize the question, if you don't mind.
Yes.
If you take breast cancer, for example, what is it that you mean when you say breast cancer? Is it an invasive breast cancer, an invasive breast cancer with brain metastasis, a pre-invasive malignancy like DCIS? So if I knew exactly what we were discussing, then I could try to give you the right answer. The same is for, say, rectal cancer with or without metastatic deposits and so on.
Okay.
Also, I want to complete my confused answer, if you don't mind, in that saying that things are changing all the time. For example, we used to say that breast cancer should not be operated if the patient has metastatic spread, but now we've discovered that those patients with breast cancer, if they are young enough, if they are luminal A, if they are bone mets, it is advantageous to operate on them. On the other side, if there is visceral mets, brain mets, lung mets, and they are triple negative, or they are of an advanced stage, these are not beneficial. So I hope I've clarified an answer that I cannot give you clearly.
Yeah, thank you. So for breast cancer, for example, at what stages of breast cancer would you prescribe surgery?
Whenever you can eradicate the cancer, I think it's worth taking it out, taking into consideration the request of the patient. I'm thinking specifically the over-treatment of low-grade in elderly, frail patients, where possibly a low-grade DCIS might never affect them at all.
Oh, great. Thank you. So what do you have to say about this is another question. It says, what are your thoughts on mastectomy? Many women for cultural reasons do not want this. What can be done about it? Many women in developing countries do not want mastectomy.
Yeah. Well, I think this is also a very intriguing one, because mastectomy, as you know, was the standard worldwide. And then we have been working jointly with radiation oncologists in limiting the surgical mutilation, particularly when those patients could receive adjuvant radiotherapy. Nowadays, because we are pretty good in detecting early breast cancer, where the disease is pretty small and you can remove it without removing the whole breast, I think this should be taken into consideration all the time. Also, it's interesting to know that because of the genetical understanding, sometimes we tend to overdo, and sometimes we tend to offer mastectomy even when a lumpectomy could be possible. Perhaps we can also offer a bilateral mastectomy to the 8%, 10% breast cancer patients who are at a high risk, familiar risk of developing metachronous breast cancer in the same mammary gland, or even in the contralateral breast cancer.
Great. Thank you very much. Okay, I have some questions here, several questions already. So the first one says, thank you for your presentation. What is the specific dimensions for negative resection margin, close resection margin, and positive margin?
If we're talking breast cancer, I think that the standard now is cancer on the ink. So if the cancer is on the surface of the lump, you want to go back. If there is a 5, 3, 1 millimeter, I think this is enough.
Great. Okay. All right. Thank you very much. Any more questions from the class? All right. Okay. Thank you very much, Professor Riccardio.
I thank you all. Thank you for arranging this and for having me with you. It's been a privilege, and I wish you all the best.
All right, thank you. Thank you, everyone. So we'll play this video again for those who were unable to attend. All right, goodbye. Thank you.
Bye bye. Bye bye.
Bye. Thank you.